Hi, everyone, and welcome to the December ASRA Hot Topics Acute Pain Regional Anesthesia Edition. Tonight, we have an outstanding panel of speakers talking about a very hot topic, ambulatory total joint replacement. Our first speaker for tonight is Dr. Sanjay Sinha, who is the Director of Regional Anesthesia and the Program Director for the Regional Anesthesia and Acute Pain Medicine Fellowship at St. Francis Hospital Medical Center in Hartford, Connecticut. He has developed a robust regional anesthesia service in a private practice setting and lectures nationally on ambulatory total joint replacement. And Dr. Sinha will be talking about patient selection and potential pitfalls tonight. Second, we have Dr. Maggie Holtz speaking on choosing the right anesthetic. Dr. Holtz serves as Chief of Regional and Orthopedic Anesthesia at WellStar Kennestone Regional Medical Center in suburban Atlanta. She speaks and teaches nationally on enhanced recovery, opioid minimization, and regional anesthesia. And lastly, we have Dr. Brittany Deiling, who is an assistant professor at University of Virginia in Charlottesville. She serves as the assistant director of the Regional Anesthesia and Acute Pain Medicine Fellowship, and her interests lie in education in regional anesthesia and point-of-care ultrasound. And she'll be speaking on the analgesic options for ambulatory total joint replacement. And I am your host. I've been the host for the ASRA Hot Topics for the last 2 years. This is my last session with you guys, but it's a great one to be at. If you have any questions tonight, please type your question in the small Q&A box at the bottom. And when finished, click send. And we'll have some time at the end to have a nice Q&A with our speakers. And if you have any unanswered questions, all of our speakers are on Twitter, or you can post to ASRA Connect as well. So I'm going to go ahead and hand off to our first speaker, Dr. Sinha.
Thank you, Jaime. Let me just get my screen. So thank you for inviting me for this session. It's a pleasure to be here, and thank you for all the viewers who are joining from different parts of the country and the world. I'll be speaking on patient selection and potential pitfalls. So in terms of my disclosure, I am a co-founder of Gate Science, but this relationship should not impact this presentation. The objectives for this talk is to review elements of selection guidelines for outpatient total joints so that patients can have excellent outcomes with reduced complications, ER visits, and hospital readmissions. It is projected that by 2028, over half of total joints in the US will be performed in ambulatory surgery centers. This migration, as you all know, has accelerated because of the pandemic. As anesthesiologists, we play a critical role in this migration because we act as gatekeepers to approve or deny patients scheduled for outpatient joints. To create a selection criteria for outpatient joints, it is important to assemble a team of surgeons, nurses, visiting nurses, physical therapists, so that the final document is acceptable to all the stakeholders. In the next few slides, I will review some of the more important elements that need consideration as the selection criteria is developed in your centers. Let's start with age. How old is too old to have outpatient joints? Now, as we all know, the physiologic reserve and the margin of safety decreases with aging. Most centers allow patients to undergo surgery under the age of 65, and with increased scrutiny between 65 and 75. The risk of complication definitely increases after 75 years. However, there is no magic number at which age patients should not have outpatient joints. All patients should be evaluated individually to assess their risk and comorbidity and not rely on an arbitrary cutoff age. Patients should be screened for cardiac risk factors because cardiac complications can be catastrophic in a freestanding surgery center. Patients with risks for coronary artery disease, congestive heart failure, valvular disease, and arrhythmias are at increased risk for cardiac complications, just like with any other anesthetic that we give to our patients. The presence of these risk factors should lead to further risk stratification and testing with consultation and with cardiologists if necessary before allowing these patients to have outpatient joints. Patients with severe pulmonary disease who are oxygen dependent, steroid dependent, and have dyspnea on minimal exertion are not good candidates for outpatient joints. And sleep apnea is a major challenge in the outpatient setting. In our center, we screen all patients for sleep apnea and get these patients started on CPAP therapy if recommended prior to surgery. Patients with creatinine of greater than 2 have a higher risk of renal and cardiac complications. Patients with enlarged prostate or a history of urinary retention in the past or with previous surgeries should be excluded because they might require undesirable catheterization or might end up in an emergency room for retention after they've been discharged from the center. Cirrhosis is obviously an independent risk factor for poor outcomes after joint replacement surgery and are not candidates for outpatient joints. Obesity, BMI of greater than 40, patients who have BMI greater than 40 have increased risk of medical, surgical, as well as anesthetic complications, and many centers will exclude higher BMI patients. When we started our program, our cutoff was a BMI of 35, which has gradually crept up to 40, and we'll occasionally do patients with higher than 45 after a face-to-face consultation with these patients. Poorly controlled diabetics have a higher risk of postoperative infections and wound complications. Patients with hemoglobin A1C of greater than 8 should be referred back to the PCP or endocrinologist for better management prior to surgery. Pre-op anemia is associated with increased risk of infection and higher readmission rates after total joint surgery. In an ambulatory setting, we do not have the ability to check hemoglobin levels or transfuse blood products. And so anemic patients should really undergo a thorough workup to determine the etiology of the anemia and the treatment of anemia prior to surgery. Patients with a history of bleeding have a higher risk of surgical complications because including hemarthrosis and reoperations. Also, patients on anticoagulation therapy have underlying medical conditions that pose additional risk and should be thoroughly evaluated and risk stratified before allowing them to have their surgeries in the ambulatory setting. Patients with recent CVA, cognitive dysfunction who cannot understand or follow directions, or conditions that impair gait and balance like Parkinson's are also not good candidates for outpatient joints because they increase the risk of falls at home. You have to rely on your surgical colleagues not to book revisions, bilateral joints, or joints with pre-existing hardware in the ambulatory setting because they require special instrumentations and can have surgical complications that are not sort of foreseen. Importantly, patients with opioid tolerance, alcoholism, substance abuse, anxiety and depression, and catastrophizing tendency have a higher risk of complications, readmissions, and very poor outcomes after a joint replacement surgery and should not be scheduled in the ASU setting. As you've gotten more comfortable doing same-day joints, we are noticing a push from the surgeons to expand indications for outpatient joints in higher risk patients. In this retrospective study, 15,000 ASA 3 or greater patients having total knees or total hips were studied, and a third of these patients, or about 5,000 of these patients with ASA 3 patients or greater, were discharged on the same day as surgery. On analysis, the study reported that the patients discharged on the same day after surgery had non-inferior risk for emergency room visits, readmissions, and mortality when compared to the inpatient cohort. Obviously, more data is required, but this study suggests that higher risk patients can be performed in an ambulatory setting. Here is a list of validated questionnaires or tools that are commonly used to assess risk and predict outcomes for various health conditions and can be incorporated in your selection guideline document. It is important to revisit the selection guidelines or the selection criteria frequently and refine or change the recommendations based on published evidence in journals, in peer-reviewed journals, as well as consensus among stakeholders, and as well as experience of the center of doing these joints. Over time, you have experience and you can sort of allow certain patients to be done in the outpatient setting, which probably you were not comfortable doing at the start of the outpatient program. Thank you.
All right. Get to my start. Okay. Good evening, everyone. My name is Maggie Holtz. I'm in private practice in suburban Atlanta, and I've been tasked with addressing the question, is there an optimal anesthetic for ambulatory total joint replacement? I do consult for Pacira Biosciences. That will not affect my presentation tonight. All right, so when we're looking at total joints or really any surgical procedure in general, we're looking at two main buckets. What is the best or optimal anesthetic for these patients, and what is the best or optimal analgesic for these patients? Brittany's going to get into the analgesia in just a moment, so I'm going to focus on the anesthesia. So let's start with some sort of hardcore science, a Twitter poll. So Raj Gupta, just prior to the ASBA spring meeting, he's out of Vanderbilt, sent out this pre-meeting pro-con poll, and he asked respondents, what is the better choice for ambulatory orthopedic surgery? So the majority of respondents chose spinal anesthesia. The minority chose a general anesthetic. I think that what is more concerning is that more people chose a bottle of whiskey than a general anesthetic, but we're going to focus on post-Civil War methods of anesthesia in this talk. All right, so neuraxial versus general anesthesia, it's kind of an age-old question. It's been looked at over and over again in the literature in total joint patients, both in our orthopedic literature as well as our anesthesia literature. So here is an article from JBJS. So this is kind of the orthopod's version of our RAPM, and looking at short-term complications between spinal and general anesthesia for total knees. Here's another one, total knee specific, looking at, again, those same complications. Here's one from the British Journal of Anesthesia, our anesthesia literature, systematic review, again, comparing neuraxial versus general for total hip and total knee. Here's an international consensus, meta-analysis, looking at the same thing. If you kind of take all of these things into consideration and look at the bottom line of all these studies, it seems to suggest that neuraxial anesthesia, when compared to a general anesthetic for total knees and total hips, is associated with a lower risk of pulmonary complications, a lower risk of cardiac complications, a lower risk of infection, a lower risk of kidney injury, a lower risk of DVT, a lower risk of transfusion, and a lower risk of death within 30 days. Cool, right? What if you have to convert? So you've got a spinal in place. Now your surgeon's taking forever, or they decide to have the resident come in. you have to convert to a general. Do you still get that benefit or some benefit from that neuraxial block? The answer seems to be yes. So neuraxial is the best as far as outcome measures, but neuraxial plus general seems to still afford some benefit over a general anesthesia on its own. Okay, so that's great. These are all these studies that have been around for a long, long time, but they're in the inpatient population mostly. Now we're talking about outpatients. Is this different in the ambulatory setting where many of our patients are overall healthier, they're overall younger, they overall have more control and more optimization of their comorbidities? Again, as Sanjay suggested, we are pushing the envelope a bit, but it is a little bit of a different patient population right now. So do these differences persist? Is this still relevant in the ambulatory setting? This was a study that came out and was published in Regional Anesthesia and Pain Medicine earlier this year and looked at neuraxial versus general for outpatients. So it was a multi-centered retrospective cohort study in ambulatory total knee and total hip patients collected between January 2017 through December of 2019, so fairly recent. And it looked at over 11,000 total patients. 10,000 of these received neuraxial anesthesia and about 1,500 received a general anesthetic. So you can kind of see already the bias of what folks are doing. The primary endpoint mirrored what the previous studies had done. So it looked at 30-day major post-op complications, so these short-term complications, specifically mortality, MI, DVT, PE, stroke, and acute renal failure. Okay, so what did they find? They actually found that there was no significant difference in 30-day major complication rate between the two groups. Now, there was a trend. So the neuraxial group had about 1.8% complication rate, whereas the general anesthesia group had about 2.3% complication rate. So there's a trend towards a lower complication rate, but it wasn't statistically significant. So does that mean we should just throw out their idea of neuraxial and go back to general? Well, not necessarily, because they also looked at other things besides that primary endpoint. Importantly, the neuraxial group had less pain, required fewer opioids, and had less nausea and vomiting in the postoperative period. These are critical measures of discharge readiness. And in fact, more patients in the neuraxial group, they were more likely to achieve that same day discharge status. This is critical, okay? We do about 95% of our total joints are in the outpatient group, right? We do very few patients at our inpatient facility anymore. The majority of them go to our orthopedic hospital or our ASCs in private practice. Neither of those have the ability to admit as an inpatient. If they fail the same day discharge criteria, I have to ambulance them to the inpatient facility. So this is a really, really big deal, okay? So taking into consideration the trend towards a decrease in complications, short-term complications, in addition to improved discharge readiness scores, I would say choose neuraxial for your primary anesthetic for your outpatient total knees and total hips. The study also looked at something else that was interesting, okay? Sort of a pro for the general anesthesia side of things. Those in the general anesthesia group were discharged faster from the recovery room. And this is a big deal in the ASC setting, okay? You might have 1 to 2 PACU bays. You can't hold that patient there waiting for that spinal to wear off for hours and hours, because those PACU bays, they might double as your pre-op bays or your block bays or your discharge bays. So there's not a lot of real estate in your ASC. So it's really important to get patients sort of in and out and kind of on their way to make room for the next, group of patients coming from the OR. So how do you circumvent this? The answer is choosing your local anesthetic that you're going to put in your spinal appropriately. So this was a study, double-blinded, randomized clinical trial from our orthopedic colleagues, okay, from the Journal of Bone and Joint Surgery, published in 2020. And they looked at sort of the gold standard isobaric bupivacaine, 10 milligrams in total knees and total hips versus a shorter acting local anesthetic, mepivacaine. And what they found was that the mepivacaine group at 70 milligrams intrathecal had a mean duration of 185 minutes, whereas the bupivacaine group at 10 milligrams had a mean duration of 210 minutes. This is not surprising. We know how local anesthetics work. Here's where it gets interesting though. So these are the scatter plots showing time to bromage 0, which means basically the patient has achieved a full return of motor function for mepivacaine on the left versus bupivacaine on the right. And you can see that the mepivacaine group is very tightly bound, right? It's very consistent. It's very predictable in its offset. The bupivacaine group is kind of all over the map, right? It seems to be really variable and not all that predictable. And in fact, about 11% of patients in the bupivacaine group took over 5 hours to achieve the return of full motor function. This is not going to fly in my ASC and probably many of your ASCs. So what's the bottom line here? The literature seems to point to neuraxial anesthesia being the optimal anesthetic for our total knees and total hips, even in the outpatient setting, okay, when you're considering all those discharge criteria. But you have to choose a shorter acting neuraxial local anesthetic with the more predictable offset, like mepivacaine. Now, there are others. This was just one that was highlighted. There's chlorprocaine, there's prilocaine, there's lidocaine. So again, you need to really be in tune with your surgeon's time and your turnover time. If you are working with a slower surgeon, you must weigh the cons of the longer duration spinal that is going to keep that patient in your PACU bay, in your ASC for potentially hours more with a general anesthetic. So that's the bottom line.
My name is Brittany Deiling. I am an assistant professor at University of Virginia, and I'm going to be talking to you about optimizing analgesia for ambulatory total joints. So I have no disclosures. Some of our objectives are talking about the reasons for failed same-day discharge, acknowledging the benefits of multimodal analgesia approach, talking about some of the peripheral nerve block options for ambulatory joints, and recognizing the importance of maintaining mobility. So our anesthetic goals for ambulatory total joints, perioperative pain management is a key component to making sure that these patients are successfully discharged home the same day. A systematic review showed that the top 3 reasons, which Maggie kind of touched on, for people not to be able to be discharged the same day were nausea, hypotension, and pain, with pain being our number 1 reason, accounting for 22% of discharge failures. Nausea also accounted for another 16%, which emphasizes the management of both pain and nausea by limiting opioids and taking a multimodal approach. So kind of 3 bullet points to keep in mind for pain management in the ambulatory center is multimodal, minimizing barriers to discharge, and maintaining mobility to promote ambulation. So going over some multimodal analgesia considerations, things that you might want to include in some of your protocols. So an easy one, Tylenol being, common, safe, and expensive in the PO formulation. It's found in many enhanced recovery protocols. It acts by inhibiting central prostaglandin synthesis, although its main mechanism of action is still largely unknown. It is commonly given along with other multimodals like NSAIDs and gabapentin, so its exact contribution may be difficult to tease out. But I think the most important point being that the existing evidence does support the use of acetaminophen in these ambulatory total joint protocols, but the route of administration does not have an effect on the efficacy. So that PO being less expensive and easy to administer in the preoperative period does not have any inferiority. So NSAIDs, both selective COX and COX-2 inhibitors, are integral components of these multimodal protocols. In a large database study, the NSAIDs were found to have the greatest single effect on analgesia and opioid prescriptions compared to other non-narcotics. And a randomized control trial showed that Selective COX-2 inhibitors like celecoxib decreased pain scores and opioid consumption and actually showed improved range of motion after total knee arthroplasty. So these are attractive options because of the decreased risk of GI side effects. But one study did conclude that all NSAIDs, when used in the short term for total joints, overall did not increase the risk of any GI bleeding unless they were combined with people who are on other anticoagulants. So the studies on gabapentinoids or perioperative analgesia are mixed, and studies specifically in ambulatory joints are absent for the literature. Some systematic reviews found benefit of a single dose of either gabapentin or Lyrica for improved pain scores and opioid consumption at 24 hours. But on the contrary, other meta-analyses have found no clinically significant analgesic benefit. Gabapentinoids have fallen out of favor more recently from ERAS protocols, specifically with joints due to sedating effects, particularly in the elder patients who make up a big component of patients getting total joints. But in the ambulatory setting, like we've talked about before, the population is a little bit younger, a little bit healthier, and more optimized. So this concern may be lessened in this specific ambulatory population. So ketamine, a randomized controlled trial in total knee patients did demonstrate that the perioperative use decreased opioid consumption at 24 hours, facilitated rehab actually all the way at 1 month postoperatively, and decreased chronic pain at 6 months. A downside for ambulatory total joints is the potential for psychomimetic effects that could delay discharge if patients are having sedation, dizziness, hallucination, and visual disturbances. So the efficacy has been shown, but although its role in the ambulatory joint population has yet to be fully determined. So dexamethasone is used for in the ambulatory setting for different reasons in lower doses, used for its antiemetic properties, very commonly used as an additive to our nerve blocks to extend the duration of some of our single shot peripheral nerve blocks. But higher doses around the 8 to 10 milligram range, a randomized control trial did demonstrate increased discharge readiness and decreased morphine consumption with 8 milligrams IV compared to placebo, with no real difference in any complication rates. And then another meta-analysis found that at doses at 0.1 mg per kg found to be effective multimodal adjunct to decrease pain and opioid consumption. So opioids, they're necessary, but it has been shown that the use of 2 or more modes of analgesia compared to an opioid-only regimen has improved outcomes, including decreased length of stay, which is very important in the ambulatory setting, lower odds of respiratory complications, and opioid prescription on discharge. And I thought this was interesting. One study showed that the ambulatory versus outpatient, they're prescribed a similar amount of opioids in discharge, but the inpatient total joint patients have significantly less risk of becoming persistent opioid users. And the side effect profile of opioids, most commonly being the nausea, vomiting, and urinary retention, definitely need to be considered in the ambulatory setting. All of these could be a potential cause of patients failing to be discharged home the same day. So our peripheral nerve blocks and local anesthetic infiltration, these are the most common use of local anesthetic for the analgesia in our total joint population. Our peripheral nerve blocks have evolved over time, which we'll discuss further, to become more selective to maintain a balance between analgesia and mobility, as it's very common for these patients to work with physical therapy in the PACU is how we do it in our outpatient setting as soon as their spinal wears off. So where I work, surgeons do local anesthetic infiltration, periarticular injections. It's a large volume of dilute anesthetic, commonly with different adjuvants that could be used, like epinephrine, Toradol, opioids, or steroids. It can vary in the injection technique, the type of injection, but has been shown to be effective analgesia of the joint. Local anesthetic infiltration is commonly used in total hips and may provide superior analgesia than just systemic analgesia alone. I think the driving home point for this is that there's currently no evidence to support that the routine use of long-acting liposomal bupivacaine for local anesthetics is superior when you compare it to just plain bupivacaine. So I think someone else had already mentioned this study, but in 2021, our iCaris group talks about using peripheral nerve blocks for total knee and total hip. This is not specifically for outpatient, but all joints. And it's interesting that it's not based on the analgesic benefits, but for the lower odds of complications, including cognitive dysfunction, respiratory cardiac events, surgical site infections, thromboembolism, and blood transfusions. So we'll talk a little bit about the innervation of the knee and some things that we can consider blocking for our outpatient knees. So the posterior knee is innervated by the popliteal plexus here from the sciatic and obturator nerves, and then the anterior knee is innervated by the saphenous nerve, 3 of the branches of the nerves to the vastus, the medialis, intermedius, and lateralis, and then our genicular nerves. So we'll go through that a little bit further. Femoral nerve blocks have fallen out of favor in ambulatory joints due to weakness from quadriceps weakness, which leads to fall risks. A more selective adductor canal has become increasingly popular in the ambulatory setting. It obviously targets the saphenous nerve, but several anatomic studies have demonstrated that the nerve de vastus medialis and some other branches are also located within the adductor canal. And so when you look at adductor versus femoral nerve block, studies have showed that the adductor canal block provides non-inferior analgesia with comparable opioid consumption, also while maintaining mobility by preserving the quad's function. And then another study did show actually improved ambulation on the first 2 days post-op with an adductor canal with similar pain scores when comparing to a femoral nerve block. So single shot versus sending them home with a catheter. Obviously, the catheter is going to extend the duration of what a single shot can give you, even with the use of multiple adjuvants. Another added benefit is that you have the ability to titrate the infusion volume and concentration, and also control how long you want that catheter in place. So one study in total knee showed that similar results in pain scores and opioid use at 24 hours between an adductor canal single shot versus catheter, but with overall improved analgesia over the 48 hours with continuous catheters, which makes sense. The incidence of chronic post-surgical pain is a major problem after total knees, and it varies all the way from 16% all the way to 47%. So these patients are good candidates for continuous adductor canal catheters. But the key is proper patient selection, appropriate patient education, and also you have to have the resources required to follow up on these catheters. And especially if you're doing, eight total knees in a day, you definitely need a lot of resources to be able to safely follow these patients. So for posterior knee pain, an IPAC block is very common. It provides analgesia to the posterior knee joint, but also maintains the sensory and motor function because it spares the main trunks of the tibial and common peroneal branches. And it targets the medial and lateral superior genicular nerves to innervate the posterior capsule of the knee. Studies have showed that the IPAC block, when combined with an adductor canal block, have shown improvement in pain scores when comparing just an adductor canal block alone. So the optimal volume that you place, which you can see here, the needle trajectory between the femur, you have your main sciatic nerve trunks up here and your popliteal artery, has not been determined, but some cadaver studies have showed that when you use over 20 mLs, you start to get spread to the branches of the sciatic nerve that cause foot drop. So analgesia to the anterior knee, you can consider doing genicular blocks along, it's ultrasound guided. You target the superior lateral, superior medial, and inferior medial genicular nerves, as you can see here. Most people avoid the inferior lateral genicular nerve, just given that it is in close proximity to the peroneal nerve and you'll cause foot drop. And a retrospective case series demonstrated lower pain scores when using geniculars plus adductor compared to adductor canal block alone. So everything that we've talked about so far is for total knees. I did want to touch on total hips. In our group, it's not something that we routinely do nerve blocks for, but the PENG block is becoming a favorable new novelty option for total hips while still maintaining ambulation. There are fewer peripheral nerve blocks given, the complexity of the innervation of the hip joint and the need to maintain motor function. But the PENG block does provide analgesia to the anterior capsule, and it targets the articular branches of the femoral nerve and the accessory obturator nerve. It's shown to better preserve motor function, specifically knee extension and hip adduction compared to a fascia iliaca block. Multiple studies have shown that the PENG block to improve pain scores in the very short term on the day of surgery, but has not been shown to provide any longer lasting benefit. But I think in the ambulatory setting, even improvement in pain scores in the short term can lead to a successful same-day discharge. Thank you.
All right, I want to thank all of our speakers, and we'll go ahead and get started on some questions. I wanted to start off for Dr. Sinha. You mentioned all of the kind of screening aspects of, for patient selection, but what are the most common reasons you see that patients fail discharge, and kind of what things have you done to, try to prevent that?
As was mentioned, pain is sort of one of them. So managing pain control adequately and sort of doing it well is important. Urinary retention, where the patients, they don't fail discharge, but they sort of their discharge gets delayed. You might have to sort of wait till they empty their bladder, especially male patients. Sometimes they're put in catheters and send them home with catheters. So I think pain and urinary retention are sort of important, two important factors that sort of delay discharge. I don't think if the patient has to get hospitalized, there's a major medical issue or a surgical complication that's happened. I think it's sort of delays or discharge is the more important aspect that we see in the ambulatory centers.
It's specifically with urinary retention. You mentioned BPH. Does that, prevent a patient from being done in a purely ambulatory setting? Is that a reason to select the patient?
Yeah, so when we started our program a couple of years ago, we were excluding patients with BPH. And what we have found is that patients who are on medications whose BPH is well managed and have had prior surgeries without any urinary retention will allow them to have surgery in our centers. And we would use a very short acting, a low dose spinal anesthetic or even a general anesthesia. So are allowed patients with a history of BPH, well controlled on medications to be done. So that's sort of one aspect of it. The other thing that we have noticed is that female patients who have had sling procedures or have prolapse of their pelvic organs are all, and now we have sort of collected a series of about 4 or 5 patients who have had this issue. So in female patients, if they've had surgeries for urinary retention or have had a history of pelvic organ prolapse, you should sort of monitor them closely.
And then there was a question for our Dr. Holtz. There was a question from the audience about they use mepivacaine for ambulatory total joint, but doses are usually 60 milligrams, but we observed two issues: slower onset, but they have a block room so you can work around it, and a higher failure rate and higher conversion to general anesthesia. Any thoughts or suggestions?
Yeah, we kind of felt the same way. We used mepivacaine for a while. We kind of were trying to find that Goldilocks local anesthetic dose, right? We started with hyperbaric bupivacaine. We had a lot of urinary retention and orthostatic hypotension issues. Then we moved to isobaric bupivacaine. It was simply too long for our surgeons. That study of just its unpredictability of offset time. So we moved to mepivacaine, and a couple of things that we saw. Yeah, one was just the delay in onset, the failure rate. And then I felt like those patients had a very dramatic rebound. It wore off so fast that they had pain. We moved to lidocaine, actually. So we use 2% isobaric preservative-free lidocaine for our total joints. We've been using it for the better part of the last half decade. And I know there's this whole, issue with TNS, but we haven't seen any, knock on wood. I think the studies that look at TNS have shown there's really, not a lot of difference between lidocaine and isobaric lidocaine with mepivacaine. And it seems to be more predictable. It seems to be a gentler offset. And we don't seem to have those issues with failure rate. So yeah, we did see that with mepivacaine. Another thing with mepivacaine is it became very difficult to get. It just kind of disappeared from our formulary for a while. I don't know if it was a supply issue, but we're kind of used to always having, in this day and age, plan B, plan C. We had moved to lidocaine when it disappeared, and we've never gone back.
Okay, interesting. I think, that's a lot of the problems that exploring these new local anesthetics or, uses of local anesthetics. So I think just adjusting them and figuring out what are the problems and how you can go forward.
So can I add?
Sure, everything is preservative free, right? Anything you put in the intrathecal space must be preservative free.
So in our center, we use either mepivacaine or ropivacaine. And the ropivacaine is slightly it's that intermediate duration between mepivacaine and bupivacaine, but has a fast onset. And so if you have surgeons of variable speed, you can use 10 to 12 milligrams of ropivacaine that gives you really good surgical conditions, fairly rapid offset, and you don't have that that pain in the recovery room that happens with a very low dose mepivacaine anesthetic, spinal anesthetic.
All right, Dr. Deiling, question: you talked about adductor canal blocks. Do you typically block the vastus medialis nerve and targeted that as well when you do your adductor canal blocks?
We do. If we see it, obviously sometimes it's difficult kind of to discern, but the goal is to get some of that lateral spread to be able to block the vastus medialis within the adductor canal. We routinely are doing adductor canal with vastus medialis and IPAC blocks. The geniculars is a little bit surgeon dependent. Some of them specifically target the genicular nerves with their periarticular injections. But the adductor and the IPAC is something that we do routinely.
And as far as, you mentioned a lot of different analgesic options for total knee arthroplasty. Is it just utilizing kind of all the variety of different techniques altogether with the intra-articular injections that seems to be best based on the literature?
Yeah, based off the literature, that's what we're doing. There's one study that shows that when you look at IPAC, adductor, and LIA, there's benefit over just adductor with local anesthetic articular injection. So that's what we are routinely doing, all three of those. We have to be careful though, because our surgeons do use quite a bit of dilute local within the articular injections. So it's something that we kind of have to constantly discuss with them, what we gave preoperatively, but it seems to have worked out pretty well so far.
Yeah, we have those same issues. Every surgeon's different in their LIA, and you have to pay attention in the post-operative period, knowing which ones got how much and how much you have to give, especially if you have a lower BMI patient. So.
Yeah, I think that communication is key. If you're going to share local anesthetics, that is absolutely key. And that's why we took it away. So I don't like sharing. I'm a control freak. So we actually do all the blocks ourselves. We don't share any local anesthetic with our surgeon just because it was just too hard to control. I think the point is, if you are sharing local anesthetics with your surgeon, you have to have some sort of communication. It has to be incorporated into your timeout process of what I blocked, what you're going to block, and how much local you get.
So we do the same thing. We don't allow the surgeons to do any taking that.
Sanjay and I are both control freaks, so
We haven't won that battle yet, but it's definitely, that's a good point. It's definitely that I didn't mention, that something that we discuss in the timeout. We do our nerve blocks preoperatively. So we kind of tell them what they have left to work with.
I think that's a question from one of our audience members about, as far as trying to get their surgeons on board with blocks. They've had some difficulty in doing that. And they're just very anti-blocks and only LIA, as well as giving some preoperative opioids. Do you have any advice for how some of the audience members that aren't able to get their surgeons on board with blocks, what they can do to help teach their surgeons?
I think start slow. Start with, just have a discussion with the surgeons and tell them that you're going to do the let's say the adductor canal or an IPAC, and the surgeon can infiltrate on the anterior aspect of the knee. And once they have developed confidence in your ability to do these blocks in a timely fashion with success and low complications, you can then advance and start taking control of the anterior knee as well. So it's a gradual process of collaboration, starting with a few surgeons. So don't try to, if you have a good relationship with a surgeon who trusts you or has confidence in you, start with just his patients. And the surgeons do talk amongst themselves. So if one surgeon, has good results, he'll tell his buddies, and so you can then get the program off and running with other surgeons as well.
There's another question about considering the patient's location and distance. If they're traveling from really far away and coming to get ambulatory joint replacement, is that an issue or concern at all? If they're traveling from a couple hours away to come have this surgery and then going home?
Yes, it is an issue. And obviously they have to have a family member. The home environment has to be good. I think what we look for is that they have to have a facility and hospital within 30 minutes of where they live. It doesn't account for the travel time, but when they're home and far away from the primary surgical site, they should have an option to be able to go to a hospital in emergency, which is within 15 minutes or 20 minutes or half an hour of their home. So we sort of make sure that is available.
And then for Dr. Holtz, you were definitely, based on the literature and everything, does lean towards, neuraxial, but in instances where, neuraxial is just not an option at certain places, whether it's the few PACU bays or block room space, or just, what are your recommendations as far as, general anesthesia and how to ensure that's not going to hold those patients up from discharge?
That's a great question. I think that you have to tailor it to your individual sort of accommodations, right? Your surgeons, how long or short they are, your staff, your availability. And so I think that when you're considering a general anesthetic for an ambulatory total joint patient, the goals are still the same, right? You need them to be functional as quickly as possible. So it's doing anything that can minimize any sort of prolonged, discharge. So using, you don't need pre-op opioids. Okay. Those are a thing of the past. You don't need intra-op opioids really, if you have a good block. Using things when we have to do a general anesthetic because a patient has a spinal cord stimulator or they didn't come off their anticoagulants fast enough, we still do a TIVA. Okay. We avoid the volatile anesthetic agents. And that way, we can really minimize that post-op nausea vomiting, because that's a big hindrance to discharge. Avoiding any sort of long-acting opioids, certainly, things like that. And we use a lot of multimodal. We use all the things that, Brittany talked about, the acetaminophen, the NSAIDs, the ketamine, the Decadron in, higher doses. And I think all of those things really facilitate the discharge post-operatively.
I think one thing, given the nausea, vomiting, I think with it in the literature, there's not really great, robust recommendations on what kind of cocktail of medications to use to prevent post-op nausea, vomiting, especially in these ambulatory cases. So, I think just making sure you utilize appropriate PONV prophylaxis. And in those, when we do the general anesthesia patients, we'll do our block pre-op. We usually do our blocks post-op on any patients that receive neuraxial, but we'll make it a point to do that block pre-op for the general anesthesia patients so they don't have as much pain in the post-operative period.
Yeah, I think that's key, because we really try to avoid any opioids pre-op or intra-op, and mostly post-op, to be honest with you. And I think euvolemia is another thing, maintaining euvolemia. I think we've really liberalized our NPO guidelines. So we actually encourage patients to drink fluids, clear fluids, up until the time they leave for the hospital or the ASC setting, because by the time they get there, get checked in, get to the block room, it's been 2 hours. And that really kind of makes it easier on us. They're happier, they're less grumpy, and they also have, lower rates of nausea and vomiting. And then you basically avoid anything that's going to cause nausea, right? Volatile anesthetic agents, opioids, hypovolemia, those sort of things.
We do the same thing. We actually have, we have them drink Gatorade up until 2 hours beforehand as well, both for the hypovolemia and nausea issues as well.
Yeah, it's interesting. One of our surgeons has been asking to explore general anesthesia as an option, where we've been neuraxial all the way for all of our joints. So it's interesting that they're even thinking about it. But I think it's also sometimes when it's one of our slower surgeons where we're kind of forced to use a longer acting local anesthetic. So there are little more delays in the PACU, but they can't get the surgery done fast enough. They're holding our hands, but so.
I think it also depends on the surgeon's interpretation or perception of you delaying their case, right? So we do all of our spinals and blocks in a block area pre-operatively. So the patients roll into the OR and they're immediately hooked up in the go. I think if you're doing these blocks and the spinal, especially in the OR, the surgeons view that as it's delaying my case. And that is, we know, literature supports it, the number one reasons why surgeons don't want blocks, because their perception is that it's delaying the case. So I think they see a general anesthetic as that's faster. Look, they just push propofol, they pop in the LMA, and we're good. So I think that there are ways around that to have that conversation with the surgeon. Look, this is better. It's supported by the literature. What are your reasons for wanting general anesthesia? Is it because you think that the spinal is delaying the case? Well, maybe we can do it in a block bay. Maybe we can do it pre-op. Does it really take that much longer to induce, a spinal versus a general? Those are certain conversations that should be had.
Yep. Someone mentioned, as far as with the early ambulation possibility for vagal responses. Have you seen that, especially with trying to maintain more of a euvolemia and to avoid some urinary retention issues? Has anyone experienced any of that as a complication?
Yes. So you will see it occasionally. But it's very difficult to sort of find the etiology, because these patients, we've hydrated them well. We have, there's no sort of blood loss that we can see. They sort of behave really well, but when you try to get them up to get them to walk, they, get hypotensive and dizzy. So yes, we have seen it less and less now with the use of mepivacaine. And I think it's more common in our total hip patients than our total knee patients. So that's sort of the observation that we've had. It is, using mepivacaine, we believe that the sympathetic blockade sort of wears off much faster. So when they have resolution of the motor and sensory function, the sympathetic blockade should also be resolving, within fairly close to those resolution of the sensory motor blockade. And so I don't know if it is a sympathetic mediated hypotension, but we have definitely observed it.
Another question, when we're talking about ambulatory total joint, that kind of means a large period of time. So obviously you have ambulatory in a standalone ambulatory center. Of course, that's ambulatory, but even the patients done in the hospital that is discharged within what they say 23 hours is ambulatory total joint. You know, is there screening that would direct certain patients to that 23-hour, or do you treat any of those patients differently as far as protocols?
So we are looking, you know, from an opposite sort of point of view, in the sense, if a patient is staying 23 hours, could we do those patients in an ambulatory setting, observe them till, let's say, 9 o'clock at night, and then discharge them home, following the same sort of protocols? And so that is being evaluated right now in our setting, instead of, because if you think about it, doing overnight joints in an ambulatory center it sort of disrupts the whole nursing staff functions and stuff. So we are now exploring this later discharge. Thereby you can do some of the sicker patients early in the morning, observe them till 7 o'clock, 9 o'clock at night, and then discharge them. So that's the point of view that we have sort of taken. So, you know, to answer your question, I think after the patient goes to bed, there's no sort of value in the patient staying in the hospital.
Yeah, I think you have to look at what are you worried about in that first night, right? Like, what are you going to catch in the hospital that you wouldn't catch if they're at home? So we basically do just about everybody as an outpatient, but we've been doing outpatient total joints for 6 years in our institution, probably longer than that. So we have kind of a longer history of it, but we're very liberal in it. There's very few patients that require an inpatient stay overnight, and it's a maximum of 23 hours. And those are the big revisions, the bilaterals, the people who are, you know, ASA 4+, because I think you have to consider what's really the point. What are you going to catch that one night in the hospital? Probably not in telemetry, just on a regular floor, that you wouldn't catch if they went home. And so we look at it that way. And they asked about the goals. My goals are exactly the same. I want that patient to be as functional as possible. I don't care where they sleep, whether it's at home, whether it's in the, you know, in the PACU because they're on hold, or whether they're, you know, on the floor or on telemetry. My goals to them are the same. Like, this is a total joint patient. I need them to be functional.
Yeah, I think that's an important point. You know, whether the patient is done in an ASU or in our inpatient sort of center, the anesthetic that we use is similar, and the objectives are similar.
For Dr. Holtz, there's a question again about the lidocaine dose that you use for neuraxial.
So we typically use between 70 and 80 milligrams, usually about 80 milligrams of 2% isobaric. I know on the bottle it says not for use in spinal anesthesia. It's preservative free. These companies are not going to do all these studies on every single nerve in the body, right? We know that preservative free local anesthetics are safe. There's a worry about the TNS. You know, studies again have shown there's really not much of a difference with, you know, lidocaine versus mepivacaine. There may be a lower risk with something like chloroprocaine if you're looking for you know, a short-acting local anesthetic, but again, those are more expensive. And we're talking about isobaric lidocaine. We're not talking about hyperbaric or using intrathecal catheters, and we really have not, knock on wood, seen this. I think 80 milligrams is kind of a very sort of Goldilocks dose for us. We do, like I said, we do all of our blocks and spinals in the block room pre-op. So we have to leave a little bit of wiggle room. Something like prilocaine or chloroprocaine is not going to work for us because we don't do our spinals in the room. Our surgeons take about 45 minutes to do the surgery, 45 minutes to an hour, but you have to add that cushion of doing your spinal, doing your blocks, getting them into the room, prep, drape, timeout, all that stuff. So the lidocaine seems to be a Goldilocks, you know, drug for us, and about 80 milligrams of 2% isobaric preservative for lidocaine is what we use.
Excellent. And Dr. Sinha, do you have a BMI cutoff?
So yes, our BMI cutoff is 40. but we will do an occasional patient above BMI of 40. So as I said, when we started, our BMI was 35, but over the years it has crept up to 40. Above 40, we have, we'll make sure that there's very little comorbidity burden. We'll make sure there's no sleep apnea issues. It's just the way how the weight is sort of distributed in the body. We have a face-to-face interview with them. We, take a look at their previous anesthetic history, and then make a decision. But our official cutoff rate, our official guideline, I should say, is 40. But we'll do an occasional patient above 45.
Okay. All right.
Above 40, sorry, not 45, above 40.
Okay. All right. Well, I want to thank all of our speakers. We have come to the end of our time, and it was a great discussion that we got to have, and we got to answer a lot of the questions. If you have any questions that weren't answered, I know that all of our speakers are on Twitter, so you can reach out to them there, and I know they'll be happy to answer any of the remaining questions we couldn't get to. So again, thank you to the speakers. Thank you to our audience for sticking with us tonight. On behalf of ASRA, I'd like to thank you all for your participation, and please remember to mark your calendars for the next Hot Topics in Acute Pain and Regional Anesthesia that is scheduled to occur on February 14th. This is my last session as the host of the Hot Topics in Regional Anesthesia and Acute Pain. Dr. Chris Schroeder will be taking over for me. So it's been a fun 2 years running these webinars, and we've gotten a lot of great discussions, a lot of great topics. So I want to thank everyone who's participated with me throughout this journey. So on behalf of ASRA, thank you again, and this concludes today's program.